record on the computer. Hi, everyone. This is Rajan Roos, the founder and CEO of the San Diego Pain Summit, and we are doing this online summit to bring to you a lot of the information that gets discussed at San Diego Pain Summit conferences and also part of conversations that happen outside the event. So today we have Mark Milligan with us, and he's an orthopedic manual therapist who specializes in the evaluation and treatment of musculoskeletal spinal conditions and is a board certified in orthopedics and a fellow of the American Academy of Orthopedic Manual Therapy. He earned his doctorate of physical therapy in Colorado. He went on to complete Orthopaedic physical therapy residency and manual physical therapy fellowship with evidence in motion. And he's a full-time clinician and owner of Revolution Human Physical Therapy and Education, a private cash-based concierge physical therapy and wellness practice in Austin, Texas. He is also the founder of Anywhere Healthcare, a telehealth solution for all providers. He teaches physical therapy programs at South College and the University of St. Augustine, and he has a lot of other really cool things he's done, and you can see that on his bio page on this website. So welcome, Mark, and thank you so much for joining us here. And one of the reasons that I had asked you to come is because you seem to be really passionate about movement, encouraging patients to move. You're also trying to encourage physical therapists to move too, because of health reasons, self-care. And so I guess maybe we can start on talking to our patients about movement and that sort of thing.
Yeah, thank you, Rajan, for having me on. I really appreciate the opportunity to. I love the idea of continuing the themes from the Pain Summit into a different format, because there's so much information and collegial networking and just conversations that happen throughout that weekend. It's tough to really encapsulate the power of connection and community through that platform. So I am definitely all about the movement. Like, I'm really trying to get people to see movement in a different light, and not only from a patient perspective, but also a personal perspective, like you mentioned. At the last summit, I spoke with Sandy Hilton about burnout and about how that's affecting a lot of people in healthcare, and shared my own story about being on that path and really seeing myself in not a good place with my health or my family or taking care of myself. And I had to switch my mental gears and figure out how I wasn't going to die early. And so I've been to the brink, and now I'm coming back, and I'm here to be a voice for others and to support clinicians moving from that aspect, but also from a patient perspective and a population health perspective. There's a myriad of things that happen to us in our lives that can be prevented, right? And movement, surprising as it may sound, can be a very powerful preventer of things that can lead to an early demise for all of us. So I'm happy to be here to talk about the different ways that movement can help and how we can help people have movement in their lives. That's the best.
Earlier, when we were talking before we started the recording, you mentioned 5 things out of 10 that movement. What can you elaborate on that a little bit more?
Right. So there's great data to support movement and how it can do things to prevent disease in our life, right? So the information about disease prevention and a little bit of exercise is robust. So the data supports that there's the top 5 modifiable killers of us as Americans can all be modified by the amount of movement we get in our lives, right? So heart disease, diabetes, lung, cardiovascular disease, cancer, and brain disorders or Alzheimer's, dementia can all be modified at some level by movement on a daily basis. And the interesting data is that it takes as little as 21 minutes a day of focused movement or purposeful movement to modify our early risk of death by 50%, right? So we can decrease our risk of early death by 50% by just walking or gardening or doing some type of intentional movement on a daily basis, right? Which
not just walking from the desk to the refrigerator.
Right. Depends on how fast
or
and how
around
far.
the house,
Right.
maybe.
No, around the house works. Like, that's the thing.
Okay.
Like, it's just got to be movement. And so, like, if there was a pill that you could take that would say, look, I can decrease my risk of dying early by 50%, would you take it? Right? And the
Yeah, I'm
question,
sure most people would.
and they would probably charge thousands of dollars for the pill, right?
Hmm.
So the issue is that our brains, human brains, are tough. They work in very tricky ways, and future threats are not readily seen for immediacy and action. And so we have to be proactive and look for different levels of engagement for ourselves and others surrounding us to help them with that movement, right?
Hmm.
So what helps you move? I'll get personal with you, Rajan. What kind of things that you think about that helps you move? I know it's you love to garden, right?
Yeah, I start getting really, because I spent many years living outside.
Mm.
So I actually start feeling really trapped and frustrated and stressed out if I don't do hiking. I do strength and conditioning with Pedro-san.
Yeah.
I do gardening, and I try and get hiking in, when the weather's right. But it's really more like something propels me to get out and do something, just because I just start feeling
Right.
I just start feeling anxious and that sort of thing. But for those people who maybe don't like exercise, like I have some friends and they're just like, I hate exercise. I try it and would it take maybe a mind shift that it's not exercise and movement? Or how would you address a patient who maybe, um, not that they're, uh, but they've told you, you've communicated with them and they've said to you, I've tried yoga, I've tried walking, I just have a hard time like wanting to leave my house or
Right.
getting up, from the office, or when I get home from work, I feel so exhausted, that sort of thing. So what's a
Excellent.
way to like
Motivate.
communicate that? Yeah, motivate the patient. Well, of course they have to motivate themselves, but surely as a clinician, we can
Yeah.
put a little spark to that.
Help influence that a little bit. And I mean, to go back to the beginning of your sharing, the fact that you can see and utilize and know that getting outside and movement for you is a path that helps calm your mind down and calm your anxiety down. I don't think I don't, let me see how I can put this. I don't know if you understand or realize how important that is, because some people look at that type of anxiety and that type of buildup and medicate for it, or self-soothe with alcohol, or self-soothe with food and drink, or self-soothe with like there's not healthy ways, or that's not a good way to put that. There are definitely alternative choices in one's life, when you may not know the power or know the outlet that can change how you manage those types of emotional feelings and how they manifest, right? So
Mhm.
it's amazing that you're able to see that path for you to help you with that, right? Versus
Mhm.
someone saying, I don't know why I'm anxious all day. They can't put a pin on it, so they go see a provider. That provider gives them some type of anti-anxiety medication because they're anxious, but it's just mainly they don't know how to manage their anxiety, right? So
Mm.
it's a really interesting and amazing self-discovery that you've made over your life that says, hey, I can do this to help this, right?
And
And
to
so,
be fair, a lot of it is I've had a very active life. So I think, and even if you look at athletes who have been really active and say they get injured and then they can't do their activity and they get that, they're like, I just feel frustrated and trapped. And so I think that's probably where that comes from, just being active in general throughout my
beautiful.
life.
Yeah, agreed. And another testament to setting that up for our families and our children is that demonstration of how movement and being outdoors is paramount, right? Like setting those examples of what it means to be active in the world versus active on a screen or active in front of a screen. I mean, there's some really interesting studies. I think I just read a study yesterday about the association of screen time and depression and anxiety with children.
Mm-hmm.
And I think that the study showed that, I need to go back and read it, so don't quote me on the science train on this, but it looked like the data supported that an hour of screen time a day had an increased risk of depression and anxiety in teenage children, right? So, I mean, if your phones will now tell you how much screen time you have on a daily basis. And for most people, it's 2, 3, 4 hours of just their phone screen time, not the other screens that they see. So I think finding a way to connect and get outside um, is an early way to help people long-term in their life. My dad did the same thing. We'd always hike and do yard work, and
Mm-hmm.
we were always outside, but that was also the 70s. I could drink out of the hose back then without dying.
Yeah.
So
And your parents just kind of locked you out for the
totally,
day.
yeah, you're not coming home until dinner.
Don't come in the house.
Right.
Come in again. I'm going to give you a chore to do.
Right. We're out, Mom. We're out. But back to the question about how we motivate patients and how we help them, right? Because as a provider, as somebody who's a physical therapist and who wants to help people get moving again, first it needs to be in the relationship that we set up, right? So I'm not here to heal everyone. I'm not here to be their savior. I'm not here to be the person that's going to fix them. I try to set up the relationship as a team that we're going to work together and walk together on the journey of their pathway, right?
Mm-hmm.
I'm there to walk with them. I'm not going to carry them. I'll maybe put my coat down over a puddle or two and help them through some of the nastier times. But like, it's for the most part, they're on that path with me. So I think sharing stories and being empathetic are one great way to allow people to see and know that you care about their health and overall well-being. I think showing the patients hope, showing them that they can change and that they should be invested in their own future, right? I mean, I think one of the most telling stories is that, if you have 5 to 7 extra years of your life, what would that mean to you, right? That would mean that you would see grandchildren or great-grandchildren, or, you would see just more wedding anniversaries with your spouse, or, there's so many ways you can connect with a patient when you communicate about the power of exercise, but really providing them with a sense of hope and that change can happen. But it just takes time and slow. But you also want to really connect on that personal level. You want to make it about them.
Mm-hmm.
You want to really show that person, look, if you move for 21 minutes a day and you get your blood sugar under control, you get your heart rate, your blood pressure and blood sugar under control, you can spend more time with Ed, your husband, who you've been together with since 1946, right? Like, make it about what they can do. Now, if they hate Ed, that's a different story. That's going to be a tough one.
So I think, especially in our society, it seems like that a lot of us, we don't tend to really understand what that means to live longer. Like, I think we already tend to feel like we're going to live longer. And it's not till we get maybe much older, like in the 70s and 80s, you start really contemplating the end of life. But it seems like for those of us who are younger and in our middle ages, because I take that life for granted. I don't really catch myself thinking, oh, I'd like more time to do this. I just assume I'm going to have that time. So then if somebody's already has that type of idea, what's a way to help them see that exercise it has more value than just living longer?
Right. That's a tough one, because exercise takes time on a daily basis, right? It takes us away from our family immediately. It takes time out of our work schedule immediately. It takes time to take care of yourself.
Mm-hmm.
But I frame it in a few different ways. One, exercise for me on a regular basis, it allows me to engage in the rest of my life in a better way, right? It changes, when I exercise regularly, I change my eating behaviors, I change my sleep behaviors, I change my alcohol intake behaviors, I change, all of those things change because because exercise is hard in and of itself, right?
And
why
it
would
keeps
you?
you looking young, right?
Right.
A good one for Southern California patients.
Right. Keeps you fit and lean,
Yeah.
right? It keeps you looking good, but it just, everything lines up better for me, and I feel better, and I'm able to engage with my family more. Secondly, I think that there's definitely great studies that show increased ability for your brain to work and function, and you become more productive when you exercise. Even though you may take an hour out of your day to exercise, your productivity and your engagement in your daily tasks improves, and your cognitive factors improve. So there's real
That's
time.
a good one too, because a lot of people worry about they don't feel like they're getting enough done, or they feel sluggish or tired or something like that.
Yeah, when most people, that 3 o'clock lull, they hit the espresso bar. That's a common thing, right? That after lunch, before dinner kind of lull, afternoon lull. A lot of times exercise during that point. And exercise, I mean walk, right? Get out for a 20-minute walk and actually change how you see your day for the rest of that day and give you that energy back. So it could be a good way to get things lively back in the afternoon as well.
Do you think saying things like using words instead of the word exercise is helpful,
Yes.
like walk
Movement.
or movement?
Yeah. Get your jam on. Whatever you like to jam on, do it. Whether that be, a scooter, whether that be, a bike, whether that be a treadmill, an elliptical, it could be a stairwell, right?
Mm.
A lot of conferences I've gone to lately, like literally we've just been hitting the stairs in between sessions. Like that's how we move.
I went to this conference recently, and it was an entrepreneur conference. And yeah, I was like, you know what? What inspired me to do the stairs was because during breaks, the elevators, I mean, it was like a 10-minute wait to get on the elevator. So I was like, you know what? I'll take the stairs. And yeah, talk about that cardiovascular.
Pretty fast. It's pretty rapid, right?
Especially when you're on like the 5th or 6th floor.
Right. But, that's how movement. So the beautiful thing about the 21 minutes a day is it's summative, right? So it's everything that you do throughout the day that adds up. So those 4 minutes that it took you to climb the stairs, or 6 minutes, and you probably did it a couple of times, adds up to your total amount of movement for the day that you need. And so getting people to convince them to help them move or help educate them, I educate them on small bites, right? It's small. It's like, I forget who coined it, or who talked about this, but just call them movement snacks, right?
Oh, I like that.
Yeah, they're like little bites of movement here and there.
Snacks.
Yeah, it's like a movement, like not a Scooby snack, but a movement snack.
I see an app coming.
Totally. Oh, that's a good idea. Another thing to put on the list. But at the grocery store, you park. It cracks me up that how many people will poach a parking space within 100 feet of the opening of a grocery store, right? They just wait for that parking space.
Oh yeah, I do that. I actually park further away because I like to walk, to have a little bit of extra walking time, because I do spend more time at the desk lately. So
yeah, that's a great way to do it.
That's a good tip.
Yeah, and that happens to anywhere you go. That's a good movement snack. Is have a little grocery store movement snack, or you do a couple of extra laps on the outside of the grocery store that you may need. I randomly I used to organize my list very specifically to be in and out of the grocery store as fast as possible. Now I do a little more meandering, and I'm okay with forgetting something, or I'll go back and forth and just add some time in that space.
That's really easy for people to do.
Totally. And I'm going to go classic for a lot of people that have weather or heat or rain. And good old fashioned, let's go back to the mall and do some mall walking, right?
Which is really good in like where I'm from in Alabama. The reason why people don't like to exercise is because it's so humid in the summertime.
Right.
Yes. At least outdoors, it's difficult for people to enjoy the outdoors.
At some points it's dangerous because the heat index is 120, 100 with the humidity plus the heat. It's actually just downright not safe. So and malls are pretty empty these days. So you can park pretty close. So you can just park close to walk into the mall and do some laps there, because malls they'll probably go away in the next 5 to 10 years, I would think. It'll be our last opportunity to do some mall walking. But great opportunity for people that they can feel safe. It's well lit. It's air conditioned. There's pretzels somewhere in the mall.
People watching.
There's people watching. So there's always going to be something that you'll have resources there. It's not like you're going to have to go out in the middle of nowhere to go for a walk. So it's a great opportunity for people to exercise. I like the idea. It's not exercise. It's movement.
Snacks.
Movement snacks.
I like that.
Yeah.
I like my app idea.
Yeah, let's do it.
Anyone listening, don't steal it.
Exactly. Hashtag copyrighted. Called it.
So another thing too that you've touched on is, I definitely also would like to talk about the biases that we have as clinicians, especially when it comes to and I hear this a lot in groups, and when I was more of a full practice massage therapist, you would hear a lot about people not following their exercises or their directions or the suggestions. And it's because people don't want to get better, or they're lazy, and I think that probably only 5 to 8% of all the patient population that would fit that. But I think for most people, there's a lot of other things. So as a clinician, how would we recognize that our bias, and then how can we communicate to the patient in a way that we can find out what that point is for them, how we communicate with them to find out what is the reason they're not able to? Because there's a reason. It's just sometimes they don't really realize it themselves, or you haven't asked them the right questions.
Right. Yeah, it's a beautiful question, Rajam. Like, and I think it ties in to what we were just speaking about with movement, right? Like when we try to get and engage patients to move, and they don't, there's always some type of blame that that one of the people wants to lay it down.
That's
right.
We want to blame
We want to
them.
blame. Yeah.
Yeah.
Totally. We in our cognitive mind need to have a reason that somebody's not doing something, right? So we typically just we take the easy route and we say they're lazy, or we take the easy route and say, oh, they just didn't want to. We take the easy route and say, you know, they just didn't see the value of my exercises. When really I think that the better way that this should be managed is we need to look at what we're doing and say, how did I not see this, or how did I not encourage enough, or what did I do that didn't allow that patient to see the value in those exercises, right? So we don't call it blame and shame, because blame and shame doesn't really do any good for any relationship, right? Because there's always going to be a victim in that role, where you can't have a partnership with it. It's just like a relationship with a loved one. It's very challenging to have an uplifting, engaged relationship when someone's being blamed for something, right? Especially if it's out of their control. So we need to look at, as providers, at our implicit biases, the biases that are there, that have been put into our lives through our education, through our upbringing, through our background, through our religion, through our thought processes, our schooling, our continuing education. Like, we need to look at all those.
Sounds like a set of encyclopedias.
It's one of those things where you can delve into the psychosocial side of your own providership very deeply, and that's an ocean you can swim in all day, right? But it really is, like, if you start it's a deep one, and I think, and people are scared of that. Like, there's self-tests you can do for your biases. There's websites, like, you just Google the top 20 biases that affect healthcare treatment and just read them, right? There's biases that I see in the clinic all the time where people think, or they're aware of, like, racial bias or religious bias or sexual bias. That should be a pretty obvious one, right? If that you're aware of in yourself. Now, that if you admit it to yourself, that's different, right? Or other people, whether it's there and you don't admit it, that's something different, right? So I think the hidden biases, the ones with obesity, or with sexism, or with skin tissue quality, or with stinky feet or bad breath, right? I mean, I say these in truth, but, like, a lot of times we're close as body workers, as people that work on people's physical bodies, that we're close enough that their smells and mainly their smells or their sounds or what they say, it really has a big impact on us, right? You can take I was a student, and one of my clinicians took one of these patients' socks off, right? We were doing a foot exam. He had diabetes, and I'll never forget, like, this giant cloud of skin just went, right? Like, the skin was just sloughing off of his lower leg due to just the amount of edema and poor tissue quality. And so I just remember my instructor at that time. I mean, he almost, like, physically got ill from it. He was like, oh my, like, he had this reaction from the patient, and the patient just put up a wall.
Yeah.
Immediately. Like, that patient disengaged, never came back to therapy that I saw, and was lost to this person's inability to understand that his bias against her feet caused that, right?
Yeah, I was getting a massage once, and I passed gas,
Yeah.
and the therapist went, ugh.
Right.
And I'm just like, oh God, I'm embarrassed. But as a massage therapist, so people pass gas when they relax.
Right.
But I never went back to her, because I was just like, it just made me feel embarrassed and shamed, and,
Totally. Yeah. And that happens in the healthcare setting all the time, right? And to be honest, it also happens outside of the room with the patient too, where other therapists get together and talk about it, which I think is even there's something cathartic a little bit about that connection with another therapist about a patient, right? But being appropriate about that patient and being respectful of that patient outside of that patient's views, I think is also a necessity or needed to happen.
Yeah, because they picked that up. I'm reading a really interesting book about, is my mic still going?
Something just happened.
Sometimes it goes in and out.
Yeah.
It's my mic, I think. But I'm reading a book about how our microexpressions affect how the people around us work under us and how they behave around us, and how we can just use, people will notice that we're using a different tone to address them than we're using to address other people, and but they can't put their finger on it, because if they were to say something, someone would say, oh, you're being too sensitive.
Right.
But people pick that stuff up, and they can't say exactly how they know that you have this bias against them, or you don't like them, or whatever, but they see that. I mean, our subconscious picks that up. Definitely.
And I think you can also see it in clinical practice, right? Like, I've seen patients that they get treated differently if let's say you're doing some work on somebody's feet, we'll bring the feet back, because that's kind of a pretty
you like
visceral,
the feet, huh?
Well, it's a real, people either, I mean, yeah, you take your sock off and you have some sideways toes and some really very odoriferous feet. Like, the person who comes in with a manicured, beautiful, sunset painted toenails that smell like strawberries are going to get completely different treatment than that patient that has feet that need some love, right? Or that someone is obese and you can't handle that in your clinic. You will treat that. I've seen patients that are physically differently treated because of how they are and who they are in a healthcare setting, and that's not okay when their course of care is completely different, right? So it's something that we need to look into ourselves when a patient. And we all, even as simple as this, we know that we make connections with patients, right? And I know everybody or clients, and I know that people are like, all right, I've got Jim on my schedule tonight. He's awesome. I can't wait to talk about softball. He's gonna be doing so great, And you look for these patients to look forward to, and then there's patients you're like, oh, I can't believe Frank's on my schedule tonight. What am I gonna do? Like, I mean, just in your thought process, you're going to handle that patient engagement better or different. Right?
So I guess the thing is to be sensitive to when you're feeling that, and then maybe observe, okay, why do I not want to work with Frank? Why do I have this feeling so would that be a good way for a clinician to start understanding that they have the bias and maybe try and work to overcome it, or at least try and hide it from the patient better,
right?
Because we can't fix things right away. I mean, things can take. I used to be that way about feet before I became a massage therapist. I hated feet, thought they were disgusting, and then as I massaged more feet, they don't bother me anymore.
That's called a little graded exposure. Feet.
That's what it was. Graded exposure.
I think acknowledging that you have a bias and treat people differently and seeing it and like feeling it, I think is an amazing way to start, right? Just understanding that person may have a different experience under your care is more awareness than most people are likely to give it, right? Because ignoring your bias and just making it okay for Frank to not get the manual therapy that Jim's going to get, just knowing that that's going to happen, I think will bring your awareness to how you interact with your patients. It'll bring you more awareness to that. And hopefully that awareness will then be like, hey, Mark, I mean, that's just not fair, right? It's just not good care to have those biases. So maybe, like you said, it's bias snacks and then movement snacks. You got to take your biases in little snacks, little bites of bias, and really just understand that they impact your care and they impact that patient's outcomes.
Especially if especially if they're both in the same waiting room. One is leaving, the other one's coming in. Frank's going to notice that you're much more collegial with, the fellow leaving, which goes along that book that I'm reading too. So it's also helped me to look at how I treat people differently with that I work with, and it may not even be that you have a bias. It may just be you feel more of a connection with somebody. So that's enough to make the other person feel like, okay, why is she treating me differently? Am I not a good worker, or, whatever. So.
Yeah, because ultimately patients want to make us happy. They do things, they enjoy pleasing their therapist, right? Their providers. They want them to know that, think that they're doing a good job and doing everything to get better. And so it's in a group environment, like many PT clinics are just kind of open floors, right? You rarely have. And so I challenge PTs to maybe sit back, or ATCs or anybody in that practice area, to sit back and just don't engage, just observe. Just observe how the clinic flows and who people talk to, and who and more importantly, who doesn't get talked to. Because there's some patients that just kind of get left out by themselves just to do their exercises, or somebody checks on them every once in a while, but the other people may be getting that engagement, and that person may not be. So I think looking at it from a systems perspective too, you'll be able to see it a little bit more clear when some people are just not getting the same treatment. So, yeah.
And from your perspective, how important is all this? So, I mean, does it really make that big of a difference, or like how important do you think that is when it comes to the patient improving their quality of life?
We can pull the data. I mean, it's an amazing point. Like, how do we know that it matters, right? And we can pull the information from Maxine Micek and the work that she's been doing in Canada, right? Like, the therapeutic alliance and the relationship that you form with the patient is the best predictor of that patient's outcomes, right? So, I mean, if you think about the relationship being the ultimate tied, no matter what your technique is or your intervention or training, it's how you connect with that patient, and that determines how well they get. Then it's everything in clinical care. It's everything.
Is there a place that you would recommend that somebody could go to find that information who might be listening?
Yeah, so with Maxi's work, if you search her work under Maxine Micek, then her articles will come up. She's published multiple times out of Canada for that, and from right now, she's the best resource that I know of. Are you aware of any resources on that?
I'm not, but she's also on Twitter. I think
she's on Twitter as well.
Maxine Micek. So yeah,
those are great places to be, and she's extremely giving with her content, and wants to share and get this out to the world, and she's still doing work on it as well. So I think, and also, like I mentioned earlier, there's places to search for your bias. You can do bias exam, like quizzes, not the Facebook quizzes, but actual quizzes that look at biases. That actually
sounds fun. Would you just Google like bias quizzes?
Yeah, totally. Yeah. And you may just be prepared for some interesting stuff. Because
I've taken some on, I think it's Stanford or Harvard has a bias, but it's more of a broad, sexual orientation bias, race bias.
Right.
Not some of the smaller,
That's a good place to start, though.
Yeah.
Because those are the ones that people don't think they have a bias in. Right. Or for most people, they like, I'm not racist. I'm not sexist. I'm not gender biased. That's not me.
But then you take it, and mine showed I had a bias towards white men.
Oh.
Like, okay. Didn't think so.
That's funny. That's weird. That's interesting. Unfortunately, most white men's lives are biased. That's the problem. So.
Well, I think my bias was assuming they were more violent than men of color.
Yeah.
That was real. But yeah, they are interesting because if you think you know how you think, and then you see, oh, wow. So it's a big old chunk of biases that hopefully people listening or watching can start to think about and consider. And I think biases are like assholes. Everyone's got one. You know what I mean? It's like, it doesn't mean you're a bad person, that we're bad people. It doesn't mean that we're outliers. It's like, we all just have it. It's just part of life. Yeah.
We're human. And the important thing is that you find out and acknowledge and move through it and work to better yourself, right? To change, to like be open and explore life and be appreciative of all humans, not just the people that you were raised with or went to
Mhm.
school with, right? Like that's
And
the
it takes
beautiful,
time too. So I think we just have to be patient with ourselves and know that we have to take those bias bites
right?
and and know it's going to be a slow process. But I think we're on our way if we're already aware of what they are and then work, to change that.
Agree. Now, this doesn't give free range for patients to be racist or inappropriate, right? Like there are certain things where, if somebody's not being appropriate in the clinic and they're
Oh yeah.
saying, yeah, that that's not a bias against that, right? That's just something they shouldn't be doing. And it's
Mm-hmm.
okay to have boundaries and tell patients that it's not okay to say those things. It's not okay to
Mm-hmm.
act that way. It's okay to say those things, right? Most people have fired a patient on some way or
Mm-hmm.
another for
For
being inappropriate.
unacceptable behavior, or if
Exactly.
they're always canceling appointments, or
Right.
you
Yeah.
know not making their payments, stuff like
Right.
that. I don't
Yeah.
Yeah, that doesn't
Yeah.
count.
Yeah.
And something I found that was interesting that you've mentioned too before is which is also part of biases, because I see that in my consulting work, is using technology in our
Yeah.
practice. Because a lot of us feel like, well, just as a side example, when I work with small business owners and they say, oh, I don't like social media, so it's not going to have any value for my work, or I don't like the internet, so there's no value in that. And there's a screen. I went to a conference a while back, and the guy had on his screen, um, don't let your uh, misconceptions screw up good business, or something like that. Like, don't let your opinions screw up good business. And so when you talked about bringing tech in, it kind of
Yeah.
reminded me of that. And I'm curious, like, what are some ways that you would bring technology into a physical therapy practice?
Yeah. So going back, I think this is an interesting tie-in to everything, right? And initially we talked about movement and that patients need to move and why they're not moving. And then we talked about our own biases and patients' biases. And really, when it's about meeting the patient where they are, and we need to tailor our commitment and treatment to the patient where they are. We need to meet them there, right? And different patients need and want to be met in different ways. Right? If you take a 70, I'm just going to be very generalist here, right? You take somebody in
Mm-hmm.
their 70s, they're probably going to want face-to-face, right? They
Mm-hmm.
want that interaction. They expect it. You take somebody in their, 40s and 50s, they're probably going to, they may like some technology in their healthcare. They may not, right? But if you start to look at the younger generations
Like 20s, don't even
20s,
call them. You
yeah,
text.
you don't, yes, exactly. So they need everything to be right in front of them and they need it right now. And so
Yeah.
one of the amazing things though is that people see their patient population as what they are right now and not what they will be in 5 to 10 years, right? Because as
Oh.
time goes by, the patient populations will change.
Mm-hmm.
And that's an unfortunate reality in the human beings' circumstances that we all move on, right? And so patients and PTs and healthcare workers in this day and age, they may be somewhere in the mid to higher end range of that age group. I mean, some of the 20s, 24, you're looking at some PTs and other healthcare professionals are kicking it in that realm right now because it takes about that long to get through school. So 20, 22, 23, somewhere in there. So that generation is starting to become the healthcare provider of the future,
And
right? And
they're already familiar and comfortable with technology in the various forms.
right, they're in that space. They use it on the daily. And so now some PT providers are most PT providers right now are of the older generation, right? The
Mm-hmm.
younger generation hasn't overtaken the old guard. And so the old guard don't really see how technology can really fit into a physical therapy practice. When it's interesting when you think about the relationship and you think about education, two of the most important things that we do for patients as a PT can both be delivered virtually.
Mm. What are some examples of that?
Examples of education. So if you look at pain education, we can just take
Mm-hmm.
a super simple one. Let's take, I'm working with a group right now. They target patients that have some type of fibromyalgia or chronic fatigue syndrome, right? You're in the physical therapy realm, you're not going to be hammering those patients with exercise and manual therapy. You're not,
Mm-hmm.
right? Those patients need a multitude of small, tiny touches over time to help modify behavior and educate and create a graded exposure to different things over time, right? Plus, you can meet them where they are. Some people with chronic fatigue syndrome, getting out of the house once, they're done for weeks.
Mm-hmm. Yep.
Right? So why would you make them come to your office to talk to you? That could potentially put them down for a few weeks when you could do it digitally and give them the information they need, check in with how they're doing, check in with their space. You save the patient travel, you save your time, and you can still get the same information to them. I mean, that would be one of the most low-hanging fruits out there.
Would that be like some of the apps that I've seen, for physical therapists? And then how does that get reimbursed by? Is that reimbursed by health insurance if you take health insurance, which I guess you're a concierge physical therapist, right? So you have more freedom.
Yeah. So the interesting thing that there's like an entire podcast episode that can be dedicated to payment and PT. It's horrible, right? Right now, unfortunately, in most states, in some states, there's parity law. They reimburse the same as they would in person for distance-based. Yes.
Okay.
Some insurances don't cover tele-rehab. So when somebody goes to a PT, they check their benefits, their physical therapy benefits. You can just check your network, your telehealth benefits at the same time. And they'll be able to tell you if you can be provided distance-based PT or not. But I'll tell you one thing, you don't even have to get paid for it. To be honest, the touches that you can do, you can set up, you just do 15 minutes with 30 patients one morning or 20 patients over a few hours, and you can really make a high level impact, because if those patients aren't doing well, they're struggling, they need to come in, you get them back in the clinic, or you progress them on their exercises and you just send them off into the world. You become a touch point in their course of care that you wouldn't have been otherwise. Right?
So what does that look like? Like FaceTime or okay.
Well, FaceTime's not HIPAA compliant, so it's got to be. It would look. Like,
yeah, that's right.
Right. So yeah,
I forgot about HIPAA.
Yeah, right. So Zoom has a HIPAA compliant version. It's about $250 a month per person. Or Skype has there's a cost that comes with it, but you need to be HIPAA compliant because of HIPAA laws. But it would look like this. It would look like you telling me your story about what's happening, and then going back and forth. And then I could email you your program, or we could email offline, or you could send comments outside of the conversation that could help progress your care. But really, it's just about continuing that relationship back and forth, so you have the information and knowledge you need as a patient to get better. So it's really, and the data is kind of starting to be shocking that in-person and virtual, their outcomes really they're not showing a big difference. They're not showing any difference in outcomes for different conditions, right? Total joint replacements, neck pain. I'm
actually not surprised by that, because we tend to have reactions to even fictional TV shows and movies, like what we see on TV or on screens, Netflix, whatever. We tend to have the same mental stuff going on in the brain as if we were experiencing it in live person. So from learning that in the past, that really doesn't actually surprise me that there wouldn't be much difference in quality of care.
Right. Yeah, it's pretty amazing. And to be honest, you can leverage technology to actually have an increase in touches, right? Instead of seeing somebody twice a week, you could do little, I call them telehealth touches.
Telehealth snacks.
Telehealth snacks. That's when we get together and eat. But telehealth touches, like these little touches you can get more over time because it's less expensive, right? So
and how would you, so like you said, the younger guys coming up, physios, it's going to be very easy. Yeah. How do you introduce this to the old guard or old dogs or, the older folks, to let them know, because, they've been doing what they've been doing for 20, 30, 40 years. Is it like maybe community courses or something like that
So I've lectured. So I'm speaking at AAOMPT. I'm speaking at CSN. I'm speaking at the American Academy of Orthopedic Manual Physical Therapists in October.
Okay.
Right. So that's 800 manual therapists. They're all fellowship trained PTs that have done a fellowship to use their hands to treat patients. And I'm presenting on telehealth at that conference.
Okay. So it's more about just introducing that concept to more
and how they can people. Just wrap their brains around it, right? How they can you don't have to treat everybody by a telehealth. Not everybody's going to want it. Not everybody's going to need it. And actually, state laws dictate that if you see something that raises some flags, you got to treat them in person, right? So there's actually safeguards that say, look, you can't just treat everybody virtually. And that's, I love that, because you can't, right? Some people will need it. Right?
And some people need, like, they can get out of their house and go to the clinic, okay, and they actually need that interpersonal connection to get better. Whereas the people, like you say, who just can't, you know, I have a friend who has a concussion for the rest of her life, and you know, we go out to lunch for 2 hours and she's beat for 2 weeks. So
that's a great point, is that the people that need it can get out, but also, and some people do need that human connection. That's part of healing, is seeing other people that had your condition and that are better. And there's ways that really works well in a clinic. But for the people that can't get out very often, this can be an interaction. This is some type of connection, at least digitally, that allows that communication and face-to-face interaction that you wouldn't otherwise get. So there's some apps out there that are you never see a person. It's just all emoji based, and videos and click-throughs. There's
I've seen those.
Right. So there are some like that do well for certain people. Some people react better to the face-to-face. Some people react to a combo, and most people use a combo of in-person plus digital. Right. So they'll have a face-to-face visit. Like, look at travel time. Some patients travel 4 or 5 hours to see a certain physical therapist. It's a great way that you go in for one, you skip a week and do digital for a week or two, and then they come back in. So then you have an opportunity to continue course of care for people that are far away. So there's cool. It's a space that, with healthcare, Alexa just went HIPAA compliant a few weeks ago, right? So
no.
Yes. So you're going to wake up one morning and cough. Alexa's going to hear you and go, Rajam, I noticed you cough. Would you like to schedule an appointment with the provider? And it's going to, they quote me on this.
And
it's going to pop
see cough medicine ads on my Facebook feed.
No, they'll drone ship you cough medicine to your freaking house.
Yeah, that's where it's going.
Right.
That's
I'm kidding you not. And
I know.
Some provider's going to pop up on your smart TV after you say, sure, Alexa, I'll have an appointment, and you're going to have a face-to-face or a digital talk, and they're going to drone ship you cough medicine while they spam you with cough medicine ads. That's totally. So I think that we've got to be prepared for it. We've got to we have to adopt some level of technology in physical therapy in order to at least be there when people, because Amazon's going to push into it. There's other spaces that are pushing into this. And PTs are like, oh, no, not me. Yeah.
But what you're saying too is, I think that will also be a boon for the physical therapy profession, because as the patients are younger and are coming from generations who are used to using technology, they're going to start only looking for physical therapists who can provide, what they're looking for. And so, those are really good points.
Yeah, you better believe it that there's when kids don't even want a call now, it's just text only.
Yeah.
They're not going to want to go to an appointment. It's going to be too inconvenient.
Yep.
Right. So we need to meet them. We need to not let our opinion of social media get in, or technology get in the way of the business practices in the way that it's shifting. That's a great quote.
Yeah, I love it. It's
yeah.
I actually wrote a blog post about it, but
that's our bias, our technology bias.
So we've covered a whole lot today, and I really appreciate your time, Mark. And I do, before we wrap it up for this discussion, what is something that you would recommend that somebody listening today, whether it be their weekend or they're going to work in the next day, what can they take from this conversation and use right when they go into work the next day?
Yeah, that's a great question. And my mind goes in 1,000 different directions. My first one is movement snacks. You got to get your movement snacks in, right? And get your patients to have movement snacks. 2 is start acknowledging your bias, right? Just start thinking and looking and feeling how you react to different patients that are on your schedule. And if you have those patients that you're like, ugh, or woo, or, or whatever your reaction is, just acknowledge them, right? Just try to start to understand, and then pay attention to how you treat that patient.
Mm.
See if your treatment is different from patient to patient with a similar or the same condition, right? And not making excuses that you can't do this or should do this. Just see if it actually is, right? So those are the two biggest things that I would say take right to the clinic tomorrow is have you and everybody you can move as much as they can, and then start to do some self-awareness, some self-awareness training. Yeah.
That's good. That's good. Go ahead and just get started and get started with it.
See how it feels.
Yeah. And you can maybe take your whole office with you for lunch, or get on those equipments, the
Totally.
equipment you have in the office.
Yes, exactly. Lots of different stuff in PT clinics.
All right, Mark. Well, thank you so much for your time.
Awesome.
I really appreciate it. And if you guys want to learn any more about Mark and what he does and telehealth, just visit his bio page that's going to be on this site for this conference. And thanks a lot, Mark.
I appreciate it.